Pancreatitis, chapter 44. Here we go. Here I have listed out the less common causes of pancreatitis, as I described on the last slide, but I have it a nice clear print for you here. We'll move on to the next slide. So again, pancreatitis can be acute or chronic. 80% of pancreatitis is caused by heavy alcohol intake, or is caused by gallstones, with gallstones being number one. Risk factors. Risk factors include being over 50, a poor dietary intake with a lack of protein, and high fat intake. Okay. Smoking can increase the tendency for fibrosis. So like I said, smoking makes everything worse. Not good. And alcohol does have a direct toxic effect on pancreatic cells. Okay, so there's your risk factors. All right. And as a reminder of the anatomy, the pancreas does feed into that common bile duct area. Clinical manifestations of acute pancreatitis. Well, abdominal pain is the predominant manifestation. Usually it's in the left upper quadrant, but it can also be in the mid-epigastric area. I'll add the left upper quadrant here. Pain will frequently radiate to the back. Remember, the pancreas is in the retroperitoneal area, and so that's why the back pain can happen. Many patients will have a palpable abdominal mass, and the pain has a sudden onset, and patients will describe it as severe, deep, piercing, and continuous or steady. And like cholecystitis, the pain is aggravated by eating. The pain can come on 24 to 48 hours after a large meal or heavy alcohol intake. Keep in mind, alcohol is the number 2 most frequent cause of pancreatitis. The pain is not relieved by antacids such as Mylanta or Tums, and the throwing up does not, or vomiting does not relieve the pain. Bowel tones will be frequently absent or decreased. The patient can have a paralytic ileus. The paralytic ileus could result in marked abdominal distension, and the lungs are frequently involved with crackles at the bases of the lungs, and patient may even be dyspneic. And with the pain, they could be even hunched over, breathing with labored breathing, and just appear really uncomfortable. The ecchymoses around the flank and umbilicus are known as Cullen's sign and Turner's sign. Turner's is the one around the flank area, and Cullen pertains to the umbilicus area. So it is a bluish discoloration that results from the pancreas actually seeping blood, related to a lot of the damage from the trypsin enzyme. Other symptoms and signs include fever, jaundice related to whether they have a gallstone causing the pancreatitis, and again the bilirubin would back up into the blood and cause the jaundice. Mental confusion could result in agitation. Hypotension can result from fluid shifts, and this can be very severe, requiring lots of fluids or albumin, and there is a loss of protein-rich fluid, and that's, these patients are often dehydrated and malnourished. The patient will often be tachycardic. They have cyanosis, cool, clammy skin. Due to dehydration, they could have acute kidney injury. Again, they may have respiratory issues with abnormal ABGs. And other common signs are hypocalcemia and hyperglycemia. So there's frequent blood sugar checks required. With patient normally being NPO, we would do blood sugars every 6 hours. That's pretty standard. And with the hypocalcemia, you could see tetany in the patient. If the pancreatitis is untreated, it could result in peritonitis, and that could manifest with a rigid and board-like abdomen. Pretty scary stuff, and this could go into sepsis. Also, I want to add with the hypocalcemia, patients can not only have tetany, but they could also present with cramps, spasms, and in severe cases, even seizures. This is an illustration of the Turner's and colon sign I was telling you about. Again, the colon sign is around the umbilicus, and I just remember the U in colon and colons, not colon, C-U-L-L-E-N-S, and the U reminds me it's the umbilicus sign, and then and the L, because there is a U in Turner's, and then Turner's relates to the flank area. Because the peritoneum is stretched tightly, the patient will often want to lean forward to reduce the pain of pancreatitis, and this could be a good NCLEX question, so please remember that. Acute pancreatitis is diagnosed with the labs of amylase and lipase, and both of these should elevate within 24 hours of the onset of symptoms. The amylase can create a false positive because it can rise with some other conditions, but the lipase is a little more specific, and the lipase will stay elevated sometimes for days. Okay. Pancreatitis is diagnosed with either ultrasound, MRI, or CT with contrast, and I see the CT used quite a bit for that. Due to the bleeding, because of the irritation of the trypsin, we may see a decrease in H&H. In fact, the patient may need blood transfusions. And with some patients, due to the blockage of a gallstone, they may present with an elevated bilirubin, and then you may see some jaundice in those patients. So this is an interesting slide on risk factors. The more of these risk factors that are present, the higher the risk of severe pancreatitis. And if the patient has 5 to 6 of these signs, there is an increase up to of a 40% mortality rate. So as I said, it can be very serious. Again, you'll note that the hematocrit can fall quite a bit. Lowered calcium is quite common. Fluid sequestration or fluid shifts greater than 6 liters could be a serious sign, and drop of PaO2 is a serious sign. A drop below 60 is very ominous. And here you'll note that elevated blood glucose is common. Okay, AST refers to liver involvement. There is a beautiful chart in your book. It is labeled Chart 50-4. It is a yellow care plan that is all about acute pancreatitis. It goes through the common nursing diagnoses and the interventions and evaluation. So that will be a terrific study guide for you. And notice here I've added the diagnosis risk for shock, because a lot of these patients need, they come in hypovolemic and they need lots and lots of fluids. Usually they will receive LR or NS, and these could be run in at a couple hundred mils per hour. So know that hypovolemia is common with acute pancreatitis. Again, please review chart 50-4. That would be great additional prep for the next exam.